He is going to talk about the role of sleep. Um, the role of sleep and breathing disorders, something he's very, very passionate about. And so we are excited to have him with us today. So Dr. Macias, I will go ahead and turn this over to you.
Thank you, Mark. Thank you, sir. Thank you, Mark. Please hold down your applause. Please, please, please. Thank you. Well, it's always great hearing Christian. He does such a great job. His office is right next door to me, so we actually do a lot of collaborating when we do some of these things with dentistry, as well as it goes with sports medicine and the face, because our floor has more head and neck than we do anything else. But he did mention, I've spoken before here on traumatic injuries to the mouth and the oral cavity, and as well as the face. And I'm not going to touch on that today. A couple little things. I have something towards the end of the presentation. You may have this, I think you're supposed to have this in PDF. If you're not, I can get you this lecture. I'm going to zip through a lot of it, because this lecture, when I give this, is a whole day lecture. And so, but I want to hit on some of the key points so that you can understand a little bit more about airway and breathing. And I took an interest in this back around probably 1991, and I had gone to a course in Austin where the dentist there was talking about, hey, have you ever heard of sleep apnea? And that intrigued me, and I knew him really well, so I thought I'd go into his class and harass him for most of the day, and actually I learned a lot. And so, and from there I started incorporating that into my dental practice. Dentists, by profession, deal with airway every day, and it has become a huge issue in the United States, in the world. And so my topic today is to talk to you a little bit about breathing and airway, and I'm going to touch on different things about sleep as well. So just to let you know, I do teach out at the Pankey Institute. It's the LD Pankey Institute. It's a dental school basically for dentists out in Key Biscayne. Other than that, I have no other disclosures, and I just keep learning every day. So I have been involved with sports for quite a while now through SAMASA, and I've known Dr. Sines since we were in the crib together hanging out when we were little kids. So he and I've been team dentists for the Missions and the Rampage, as well as the Spurs. And so I teach quite a lot. I enjoy teaching. It's, you know, when you have all this information, you want to disseminate it to somebody else so that they can learn from you. And but I tell you what, I learned from some of the best. And the only reason I can see as far as I can see in what I teach is because as this phrase goes, I've stood on the shoulders of giants to be able to see that far. So this is kind of what I look for when I treat patients on a day-to-day basis. It's risk assessment. We're just kind of see what's going on, what is their chief concern, and then I start my process of learning. But the main thing that I have changed from facial aesthetics, people come in, hey, I just want bleaching, or can you make my smile better? I start looking even deeper, and I go into airway. Because airway is, if you don't have a proper airway, you're not going to have good function when it comes to your dentition. And so that's a big thing now in my methodology when I'm looking at it. Airway and sleep. Of course, you all know in the ABCs is airway, breathing, and circulation, right? Airway is the first one, right? So I'm going to talk a little bit about sleep. And please, I hope nobody sleeps while I'm talking about this. But this sleep is a phenomenon that most mammals have, and even some non-mammals, and it's just a loss of consciousness. And we all sleep. We all get to the point where we're so tired we've got to go to sleep. And then you're awakened only by certain stimuli, whether somebody startles you, a sound, and that overcomes. Now, if you were my wife, she can sleep through a thunderstorm, you know, and some people sleep so deeply. Now me, I get rustled pretty quickly. So when my kids were little, they would go around the bed to me rather than directly to my wife. But that's the way people are. People sleep in different states. So we really need it in order to be successful in what we do on a day-to-day basis. especially when it comes to athletic performance. I see this quite a bit because I see a lot of athletes that come in and we talk about their sleep. And as you know, most from high school, probably from late middle school until college, sleep deprivation is huge in these students because they go to bed late at night, or they may be at practice and then they have to go do homework, and then they have to test tomorrow, and then they have a game that afternoon, and they're going to bed at midnight, 1 a.m., 2 a.m., and getting up at 6:30, 7, and not getting enough sleep. So there's a difference between having good sleep, and having enough sleep. So mental health, safety, quality of life, right? So there's different types of states of sleep, and I'm just going to touch them real quick. There's what's called NREM, which is near REM, and then there's REM, and you've heard of that, REM, right? So most people sleep in NREM throughout the night. It's not until the morning that we start going into REM sleep. REM sleep is when your body is almost completely paralyzed and you're not even moving. I mean, you are just hypotonic. You're not moving around at all, but your eyelids are, and they're rapidly moving. And near REM is a stage where you're kind of dozing off, and then you start going to sleep, and then you get in. And you can dream in near REM, but you dream mostly the vivid dreams in REM sleep. So there's stages of it. 75% of your sleeping at night is in near REM, and then 25% is in REM. And this is the way it works. If you look at this graph here, you look at it, you're awake, you're getting ready to go to sleep, and then you start getting light sleep, and then you go into deep sleep, and then you're way down in the third, which is really the fourth level, and then you start coming back up. And this usually occurs right around 4 to about between 5 and 7, depending on what time you wake up. Usually about 2 hours before you wake up is about the time when you're going to start hitting REM sleep. And we sleep in cycles. We sleep, as it says there, in 4 to 6 90-minute cycles. And that's when you get into these deep places where your breathing changes in those 90-second. And of course, that's where snoring really you can see snoring go like this all night long. Although when we talk about snoring versus sleep apnea. So we need near REM in order to get our nerves back into shape, and then we need it to be alert during the day. And when you're growing as a child and into a young adult, you need it for growth hormones. That's where it's replenished at that time. It's an amazing thing. There's still a lot of things we don't understand about sleep, but there's a lot of things we do know that work out with sleep, especially when it comes to memory. Especially when you see memory, the transfer of information that gets caught into your brain, that you sit there and go, whether it be a smell, or whether it be something that you did as a child, and that, you see that what happens even in geriatrics, where like my mother-in-law, I would say, Mom, did you eat lunch today? And she was like, I don't know. She couldn't remember, right? But if I asked her, hey, do you remember the time you bought your wedding dress? Oh, yes, let me tell you, I was downtown San Antonio, I took the bus, and I got down there, got there about 2:30. I mean, they know this. So those little pieces of memory get in your brain somewhere, and then it brings it back. But as you get older, your memory changes, right? Your memory changes. Learning, and then, of course, your mood. We all know people who say, man, you didn't get a good rest last night, right? You're grouchy today, and that happens. It affects our moods, right? So sleep disordered breathing, as part of airway, is interrupted sleep while you're, and it can be anything. Somebody could be waking you up, or you could be waking yourself up. I've seen many people who have been sitting back in the lounge chair on a Saturday afternoon, and then they're like, and wake up like that. And that's just part of the sleep disordered breathing. OSA, as we define it, is obstructive sleep apnea. It's the most common part of sleep disordered breathing. We see this in a ton of people. I'm going to glance over that in a little bit, but again, I'm always accessible if you want to learn a little bit more about this. But so some of the symptoms of sleep disordered breathing are, like I said, snoring, right? Bruxism. Bruxism is grinding of the teeth. It's biblical, the wailing and gnashing of teeth, but it is grinding, all right? Now, and then there are anatomical symptoms and psychosocial health issues. So why bruxism? Why do we see that? And you can see that on yourself, or you might see that on some of your athletes. Because when you start getting to lack of sleep, or good airway, I should say, lack of airway, what you're going to find is that your CO2 levels will start increasing while you're sleeping. And then we have a pathway in our brain that recognizes the amount of CO2. And so it starts going in there and saying, we don't have enough oxygen. So I'm going to have the teeth come together and grind. And when they do, it creates muscle tone, because when you get into deep sleep, you lose muscle tone. You become hypotonic, right? And so, so when you lose muscle tone by grinding, you create muscle tone. And when you create muscle tone, your teeth come edge to edge, right? And you open your airway. And so that's a way, a mechanism of being, for the body protecting itself, right? So snoring is just the walls of the throat just kind of getting soft, and they flutter. And it's usually, you think it's the uvula, the bell part of your throat, but really we find that it's a combination. It's sometimes can be the epiglottis, sometimes it's the tongue, sometimes it's the soft palate, and it's a combination of those three many times. And it's based on this, the Bernoulli effect. And many of you have gone on, going with your students on a traveling date. And as you go to where y'all are going to be playing, you get into the hotel, you get into the shower, you turn on the shower, you step into the shower, you close the curtain, and what does it do? It comes up right against you, right? And then you got to push it down to move it away from you. That's called the Bernoulli effect. So what happens is as air, or any type of velocity of anything, whether it be water or air, as it's going quickly, it causes low pressure. That's the way a plane works. As low pressure goes over the top, fast pressure is going underneath. I mean, you get low pressure underneath because everything is running underneath over the top of that wing. You create low pressure and everything rises. Same thing, it pulls in. Same thing happens in the throat. The soft tissues get really, really soft, especially as we age. And as the diameter of the airway coming in is minimized, you get fast. It's like when you get a hose and you pinch the hose, the water's going to shoot out fast, right? As you close off that orifice, right? So why do we care? Really, because between the ages of 30 and 60, and 1 in 4 men and 1 in 10 women have some type of sleep disordered breathing that we know of. And we see it in children. And because as a dentist, I can see them at least a couple times a year, I can identify this in children. And then we can treat it by, this is a mandibular advancement device. I'll show you in a minute what that is. And then we can manage sleep disordered breathing over time. So it's common. It's really potentially dangerous. It's like, hey, I remember as a kid, not too far from here, one of my uncles lived, and when my parents went out of town and we stayed with my uncle, my sister ran in the middle of the night to me and she goes, Uncle Gilbert, he's a dragon. And I go, why? And she goes, listen to him. And he was like snoring up a storm, and then he'd stop. And that is sleep apnea, right? So it's deadly because your blood pressure raises, your heart is really pounding because it's not getting enough oxygen. You just basically hold your breath. Sleep disordered breathing and obstructive sleep apnea, what happens, I ask any of you here to hold your breath for 1 minute. It's tough. But people with obstructive sleep apnea can do that over a minute, over 90 seconds of holding their breath. What that does to the heart and everything else in your body is amazing. So it's easily diagnosed and treatable. And so it can cause, like I said, cardiovascular disease, high blood pressure, diabetes, obesity. And the opposite is true. With the widening of America, unfortunately, and we all get it. Sometimes it's genetic, sometimes it's environmental, sometimes it's, I just ate too many Cane's chicken strips that day. And so you have to deal with it. It's a reality of what's going on with that. There's 18 million people that we know of that we think have sleep disordered breathing in the United States. There's 330 million. Actually, I'm a member of a breathing learning group. It kind of sounds weird, but it's all talking about sleep disordered breathing. And we just met on Tuesday via Zoom. And 330 million people in the United States, over 40% have sleep disordered breathing. That's the latest statistics. And of those, how many are getting treated? 0.6 of that 40%. So there's a lot of people out there with sleep disordered breathing. So you're a lot in fact, it's this last slide here, 6 times more likely to have a car accident. I was dreaming last night. I sleep pretty well. I've treated myself because I did snore for a while. And one of the things that I dreamt last night, it was really weird because I guess I was preparing for this lecture, is I dreamt that I was driving to Austin and the median was all beautiful smooth grass like you would find on a golf course. And I was in a blue Tesla and I was driving, and the next thing I knew, I was on the smooth grass. And then I went, I recognized it, and I got back on the highway, and I kept going. And then I said, I need to review. Teslas have like a camera that go on you, and I reviewed the film, so to speak, and I had fallen asleep. That was my dream this morning. I mean, it's amazing how your dreams can be very vivid, from black and white into color, and even into smells, right? Crescendo snoring. So that's, and I had some videos, but it's hard to link them up here, and I can share those with you later. But crescendo snoring is, and I'm going to kind of see if I can mimic it here. It starts. That is crescendo snoring, and you see that it starts out real low, and then as you get into deeper and deeper, it gets really loud. And then a lot of times, like I said, you can wake yourself up by that. So we have these things called RERAs, and I'll talk about that in a minute. But there's a part of snoring that you can become what's called a non-sleepy snorer. So during the day, you function well. As long as you're active, no problem. And that's called upper airway resistance syndrome. It's just that you're snoring, you're really closing the diameter in your airway, and you have resistance from that. Apnea is where you stop breathing for 10 seconds or longer, and hypopnea is when you get a 30% decrease in O2 and a 4% greater DSAT. And so RERAs are the respiratory effort. All these things are just what the sleep doctors look at, and really, there's a thing called apnea-hypopnea index. I use these, but I don't ever really give a lot of credit to them because they're changing day to day. So the main thing is I'll go back here, is when you have hypopneas, everybody will have maybe a hypopnea while you sleep. And it goes from mild, 5 to 20 per hour, 21 to 40, and 41 per hour, and that's severe sleep apnea. So you basically 41 minutes out of your 60 minutes is in not breathing. And so this is the one that I want you guys to focus on. Normal, you breathe fine, you don't snore, no problem. Non-sleepy snorer, you snore a little bit, not a problem. And then the sleepy snorer, where you're actually getting to the point that if you turned off the TV or had something and sat in your lounge chair in the afternoon with a hum of the air conditioner, and you'd fall asleep. And then the obstructive sleep apnea, those people fall asleep all the time. And these people there's a lot of things that you can see in them. So this is a lot of time. This is called spousal arousal syndrome, okay? And you say, because I'll ask patients, do you snore? And they go, no. And the wife will go, oh, yes, he does. And then he goes, well, it doesn't bother me. He goes, yeah, but it bothers me. And so what you'll see is that you'll see bed partners, they'll end up sleeping in different rooms just because of this. And so it's a very, very common problem. You notice this guy's on his back and he's got his mouth open, right? That's a very, very common thing. And I'm going to talk a little bit about mouth breathing versus nasal breathing, right? And I don't think this has, oh, well, maybe. Here, let's see if we can get it here. No, you're not going to hear it because it's not linked up. Okay. Well, here I go. Now, there's the apnea. There's the apnea. So so what you hear there, he was quiet, right? I said, well, he doesn't snore. Well, wasn't breathing. He wasn't breathing. The air stopped. He was quiet because I've heard so many patients will tell me, oh my God, I have to reach over and push my wife or push my bed partner or push my husband and say, hey, wake up. You're snoring or you stop breathing, and they get nervous. I've had several patients who say, we've got to do something for my husband because he just sits there, he gets so quiet. And I'm wondering if he's dead or alive. And so it's so true. Now, I used to think that when somebody come in, remember I talked about grinding bruxism, I used to think that we had wear, if you look on the picture on the right, a lot of wear on the front teeth and anterior wear. And I used to think, well, these people are just grinding, right? Well, remember I talked about it, that when you protrude your jaw edge to edge, you do that to open your airway. And so now when I see somebody like on the picture on the left, I'm not really, really concerned with snoring, although I could. I mean, you have to really look. I can't be so naive. But when I see somebody on the right, where the front teeth are really worn down, it could be other things. It could be biting their nails. It could be biting on a pen, that type of thing. But normally when you see pathways of things that are fitting, like, for example, you see this, where all these little evidence of grinding, all these pictures are actually pictures of my patients, right? So I used to make a night guard. And a night guard can create a good thing, but it can also create a bad thing. So this is the main thing that I see. I see scalloped tongues, right? What that is a lot of times in the old days, they would take away 4 bicuspids in extractions for orthodontics. Well, you're just constricting the space in the mouth, right? You're constricting the airway space. Or you see this on somebody who there's actually fat in the tongue. So when you increase your fat diameter, you increase fat to the tongue. And so it pushes out. And what you see there, that little scalloping in that is the teeth marks, right? How it fits against the teeth. And they fit, on this one, you can actually see on the lower front teeth, the 4 lower front teeth, how it fits right there. So this, and a little aside, I'm a Catholic deacon, right? And so I'm assigned to San Fernando Cathedral. And I give out communion quite a bit, right? That's what I do. And so when people come to communion and I look at this and I go, I could help you, I could help you, I could help you. So, just joking. So the other thing is the symptoms that go along besides the scalloped tongue is something called GERD, right? Gastroesophageal reflux disease. And this is very, very common. Why? Because when you close your airway off, your diaphragm continues to contract, right? And it's pulling down like a bellows, a bellows back and forth, and it's pulling down to bring air in. That's how it works. That's how we breathe. Our diaphragm is doing it. The vagus nerve, it goes to the diaphragm, and as it contracts, it brings air in. But when the air is stopped because of you have an obstruction, now what you have is you have the esophagus right through that diaphragm, right? And it's sitting there, and all of a sudden, what does it do? It squirts acid back up into your throat and into your mouth. You get this where you basically vomit in your mouth at night while you're asleep. Many of y'all have had it. It could be midnight, you head out to Taco Cabana or something like that, and then you get home, and man, you got that little heartburn, and that will happen. Mark Ruiz is laughing, But this can happen, and you see this a lot. Now, you also see this in people that have some type of bulimia where they force themselves to throw up. But this happens, and this is something that is very indicative. And you'll say, do you snore? Yes. Do you ever have like reflux? Yeah. How did you know? Well, because it goes hand in hand. Now, you can have silent reflux, where it's kind of like a burp, right? And it's a burp, but it's so acidic. The air that's coming, basically the air that's trapped into your stomach, when you burp, you're burping some of the acid, basically, in an aerosolized. And you can still get that without actually having contents into your mouth, right? So the other thing I see is what causes airway obstruction, these tonsils. You see these in children a lot. Kissing tonsils, they call. Can you imagine? There's no airway there. And you got the obstruction between the tongue, look at the uvula there. We have nothing. This is actually one of my patients. I'm going to talk a little bit about it, but I'll go ahead and give you what happened with this patient. They brought her in to see me because she was grinding her teeth at night, and she was like I think she was like already 12, 13 years old. And I looked in the mouth and I went, she's grinding her teeth. How are her grades? Grades? Why would you ask about that? She's like a C student. And I go, really? I said, yeah, the doctor's, she can't focus. So the doctor has her on Ritalin. I go, oh, interesting. I said, you know what? I'm going to send her to, I have a friend of mine, Dr. Bonilla, the pediatric nose throat group, he and his brother. And I sent him over to Juan, and Juan went in there and removed the tonsils. She's off of Ritalin and is an A student now because she had lack of focus because she had lack of sleep. She was never getting into good sleep. So that was causing the focus. So a lot of times we see now that, and I'll share with that a little bit. You can do all kinds of diagnostics on CBCT, and there's actually one where you can put it down the nose and see what the volume is in the mouth. But I rarely use these, right? But one thing I do is that when I take images like this, you can see by moving the jaw forward in the right picture how the airway is opened. And that's part of what we do and how we treat this, right? You just move the jaw forward and the airway opens. Same thing you do when you grind your teeth. You bring your jaw forward to open the airway, right? So, some of the symptoms: restless, non-restorative sleep. Part of all of this is restless leg syndrome, choking or gasping at night, reflux, heavy sweating, and nocturia. Nocturia is where you have to get up and pee all night. Daytime symptoms: sleepiness, falling asleep, especially when driving, morning headache, sore throat, dry mouth, right? Not doing well, and then sexual dysfunction. A big part of obstructive sleep apnea in a man is impotence, and so they're dealing a lot with that. Now, there's a correlation here in Viagra and because that is nitric oxide and when we breathe through our nose, we create nitric oxide. So all these things can go on. Once you get to this point, it's like a vicious circle of depressions. You can create stroke, heart failure, severe obesity, hypertension, coronary disease, AFib. Yeah, a lot of people, I have one of my friends has an Apple Watch like I do, and he had bad sleep apnea, and he actually, his watch saved him, found that he was an AFib. So, diabetes, sleep apnea, they go hand in hand. A big part of that is because of the intolerance of have type 2 diabetes. And so, other things like high blood pressure, I've already kind of talked about these. Cardiovascular, arrhythmias, which we see quite a bit in these people. PVCs, like preventricular contractions of the heart. And then cerebrovascular, like brain strokes and that sort of thing. Increase in cholesterol, and then hardening of the arteries. So what causes it? Well, the dilator muscles, like I said, in the throat kind of get very soft, and especially as we age. And then the muscles just can't stabilize the jaw. And the next thing you know, you get airway collapse. So other causes, you could have, like I talked about, 4 bicuspid extractions. Genetically, you could have a deficient lower jaw. You can have upper airway, like blockage of your nose. You can have that, like, Christian was talking about injuries to the face. You're going to see this with your athletes. Injuries to the nose where you have a deviated septum. You can't breathe through your nose. You're having to breathe through your mouth. Enlarged uvula, tongue, and then a nasal valve collapse. And I brought something here I'm going to talk about a little bit, and I have a gift for all of you. I don't know if I brought enough, but if you like them, if not, you have some information there on it. Excuse me. So I'm not an early bird or a night owl. I'm just an exhausted pigeon. That's what I am. So how do I screen for this? This is you can find this you just Google this, or you can find it from this, just copy it off. And this is called the Epworth Sleepiness Scale. And it's basically a little test that you can give your athletes or give yourself on what would your chances of dozing off in Dr. Macias' lecture, what would your watching television, sitting quietly, and in a car. So then you total the score right there. And then if it's a score of 10 or greater, it's possible that you have some type of sleep disorder breathing. So this one here, Epworth Sleepiness Scale, by far, I use this every day, right? Now the other one is called Mallampati scoring. And then you look when I look at in the mouth, if you as a trainer are looking, I know y'all look into throats, right, to check. I call it the Hawaii technique. If you have the patient say, ah, in a very low voice, as low as they can do, go, aloha, aloha. That's why I call it that Hawaii technique. If you say it really low, you can usually see into the back of their throat. The tongue depressor, and they go, they do it through their nose, you're never going to see anything. Just have them go, say ah as low as you can say it, and open your mouth and say ah as low as you can say it, and you can see all the way back down there. And so this is how we score. If you can't see, and they've done that, then they probably have some type of sleep disordered breathing. The further you get to the right, class 3 to class 4. The other one here is called stop bang, right? And as you can see, it's snoring, I'm tired, somebody has seen them, like a bed partner, elevated pressure, right? Body mass index, older than 50, neck circumference. If your neck is more than 17 inches, 17 or above, you might have sleep disordered breathing. And of course, gender, males being more prominent than females. Now, I do have some patients that are severely obese and no sleep disordered breathing at all. And you could swear that that's what they have, but they don't. And so sometimes it's just anatomic, right? So I ask the question, do you snore? That's the most common question that I ask. Do you snore? And I go, well, I don't think so. And then somebody, oh yeah, you do. So there are home sleep studies, which I find are much, much better than an in-lab, because in-lab, they're going to hook you up to all kinds of different things, right? And so, they hook you up to an EEG. You know what an EEG is, right? Right? Electroencephalogram. And an EKG is a electrocardiogram. And an EGG, you know what an EGG is? It's an egg. So just as one. So just that you know that, just if you didn't know that. Okay, just trying to keep it lively, waking you up here, okay? So this book here by Sharon Moore is very, very, it's a wonderful read for if you treat really, really young children. It's called Sleep Wreck Kids. Kids that are not getting a good sleep. Like I said about my patient who was diagnosed with sleep apnea as a young child, right? And it starts very early. It starts very early, even from when they're first born. But you can see the dark circles under his eyes here, right? So it's imperative that as dentists look into this, right? Kissing tonsils, like I showed earlier. Ankylosing. This is something where you're tongue-tied, right? And does your child, I ask these questions, picky eating, or do they gag when they eat? They lisp, they grind their teeth, snore. Do they fall asleep, can't concentrate? I evaluate them for tongue tie, because this starts at an early age, right? And they get right here. This is just a newborn right here. The tip of their tongue is attached to this. It's called ankylosing. It's a genetic trait that happens. And so what happens is, when you've heard of women who say, oh, man, my child just won't latch on. I'm trying to breastfeed. They won't latch on. And so they have a problem with it in breastfeeding. So what happens is that because their tongue, the way breastfeeding occurs is the tongue goes up under the nipple and starts, as it, so to speak, just kind of going up underneath it. It draws down the milk, right? But when you have a tongue tie in the front, the palate will raise up instead of the tongue coming forward. And when the palate raises up, you change the anatomy of the arch. And so you get a very deep, high elevated arch in the child. This is the beginning of adult sleep apnea. Because when you get that real high arch, instead of the outer teeth being on the outside of the lower teeth, the arch gets real high, then you get either a crossbite or a unilateral crossbite. And that's the way the teeth come together. And so you're actually creating, so what happens if you can't nurse very well, there are very many studies that show that children that nurse have less ear problems. They have like earaches and where they put tubes in the ears. And also, they get the IgA, IgE that they need, the antibodies, so that they can have better tonsillar function, right? They don't get as sick as often. So here, this is just a lovely little girl, but she's sleeping with her mouth open, right? And mouth breathers are do not work as well as nose breathers. You can see this little girl. This Lauren Ballinger is a real good friend of mine. She's in my sleep study class. And so Lauren's a pediatric dentist, and she deals only with sleep disordered breathing in children. And so you can see this one girl, just look at the circles, dark circles under her eyes, and then look at her in the 2 years later, right? And that's because she had, again, large tonsils, got the tonsils removed, sleeping better, took care of what the problem was, right? So this is what I was talking about earlier, ADHD, young children, children that are active, reactive, hyperactive children, and or children that snore or grind their teeth. This can now, not always, but can be linked to sleep disordered breathing. So we have to look at those things: poor skills, poor academic skills, poor grades. So it's something that it's not everyone, but it's something that you need to look at. And I see it more often than not, right? Behavior, you see children that are just hyperactive, they don't sit well, but they also could have change, especially young children that are nowadays, or because of diet, that sort of thing. It's a lot easier to buy a McDonald's cheeseburger than it is to give a child a healthy meal. It's cheaper, it's more economical, and you'll see that especially in socially deprived socioeconomic backgrounds, where it's easier to feed a family of 4 on fast food. And of course, we know how that risks, especially with a high sodium, and that goes along with it, right? So treatment options in children, the ones that have the little tongue-tied, we can do remove with a laser. Remove that. It looks awful, but it heals within like 2 days. Back in the Middle Ages, the women that used to deliver babies, they would let their pinky nail grow. And they would get their pinky nail grow real long, and then they would sharpen it on a stone. And then when they delivered the baby, they'd look in the baby's mouth, and if the mom had trouble nursing, they'd look in there, because back in those days, there was no formula. You had to breastfeeding was the only thing, or they had wet nurses, right? But what they would do is, they've noticed that they would take their pinky nail and they would go and sever that tongue tie. So in adults, CPAP, continuous positive air pressure, CPAP, right? And this is so romantic, especially when you just get married, right? So I had a patient of mine that I made her husband an appliance. And she had, it was so funny, because she came into me and she goes, my husband, we never slept together before we got married, and then when we got married, we went on our honeymoon. She goes, I didn't sleep for a week. I didn't realize he snored so bad. I knew he snored a little bit. So he came in, and I made him a CPAP. I'm not a CPAP, a mandibular advancement device. And then, so I get a note on my desk the next day, and it says, Roger, had a great night last night. I love you, Mary Jane. And then that was great. I was like, all right, he slept well. I was really happy for her, right? Until my wife came in and saw the note, said, Roger, had a great night last night. I love you, Mary Jane. And then she was like, what? And I go, I was with you all at home last night. So anyway, but the problem with CPAP is that nobody wants to wear it. I mean, nobody's going to wear this mask. It's cumbersome. It works. And I've been on a lot of retreats where you go on men's retreats, and I tell you what, it's awesome when the guy next to you's got a CPAP, because that little hum, man, it just like puts you to sleep, the little white noise. But nobody's going to wear it. So there's this other thing called the LOP, the laser-assisted uvular palatal pharyngoplasty, and really they go in there with a laser, and it's the worst sore throat that you can imagine. You thought COVID sore throats were bad. This is like, swallowing razors, not good. And then it leaves you with a beautiful scar. Takes away your sleep apnea for about a month, and then your tongue will kind of grow to the size of it, and the next thing you know, you got sleep apnea again. So Dr. Keith Thornton, he's one of the guys that I've stood on his shoulders. He's one of my dearest friends, and he's out of Dallas in the Plano area, and he's devoted his life. He's the one that I went to the lecture on, and learned a lot from him. And so he came up with this thing called the TAP, which is the Thornton Adjustable Positioner. And what it does is it just keeps your jaw from coming back at night while you're sleeping. So it keeps your airway open. And the new one that has come down, which he and I had talked about many, many years ago, of instead of bringing the patient forward, we bring the patient down and forward. It's a less strain on the joint. The previous up tap has a lot of strain on the jaw joint, but this one, by just opening your mouth and coming forward, as you see that's directing down, this is called a flex tap. And it actually, we're getting really good results. I've only done 2 in my office, but overall in Texas we've done over 500, so we have some good results with this right now. If you haven't read this book, this is a book that you need to put on your shelf. Order it on Amazon. It's life-changing for me. It's called Breath. It's by this guy named James Nestor. James Nestor is a journalist. He's not even a scientist, but he went in and did a lot of in-depth studies on breathing. And I would put this on your shelf, and it's an easy read. You'll have it read in a couple of days. This is him, 5 Ways to Improve Your Breathing with James Nestor. You can find all of his videos on YouTube. They're amazing, right? So mouth breathing versus, and this is, the book basically was talking about mouth breathing versus nasal breathing. So the little girl on the left, mouth breathing, the little girl on the right, nasal breathing, right? So what happens? Our sinuses here are in front. We have all the different turbinates, and that's the anatomy of the nose. But really, we have like filters in our nose, just the nose hairs that we have, and it filters out all of this dust, cedar. When you get overwhelmed by cedar in Texas, you know, it's a tough thing here, right? And then the dark circles under your eyes because overbreathing. You're overbreathing. You're not breathing correctly. You're overbreathing, which is so it causes you to slow down your breathing pattern by getting your airway better, because the little ducts underneath your eyes create that little dark circles. Our bodies were designed to breathe through the nose. So breathing through your nose is sympathetic, you know? Sympathetic meaning sympathetic nervous system. Breathing through your mouth is, parasympathetic. Breathing through your mouth is sympathetic, right? So fight or flight, I'm running away from somebody. Relax, sitting there. Sympathetic. So breathing through your nose actually lowers your blood pressure, whereas breathing through your mouth elevates your blood pressure. And you've all seen where you go and you get a test and go, hey, my blood pressure's a little high. All right, sit down and just breathe through your nose for a little bit. Well, you didn't even know it, but you were recommending some parasympathetic breathing, and that's what you should be doing. So nasal breathing humidifies the air. You've been in climates where it's super cold, and it hurts to breathe through your nose, right? And then nitric oxide, like I mentioned earlier about Viagra. So nitric oxide is produced in the nose, and it travels down in our breathing, right, into our lungs. The lowest alveoli in the lungs, it acts as a surfactant. And that surfactant, which makes it kind of moist and allows the blood flow to increase around those alveoli so you can take in more air, more oxygen. And so nasal breathing is important to create that nitric oxide. Viagra works the same way. It increases blood flow, right? And so that's what you use for on that. So part of that flex tap that I showed you, we now have a little part that fits on the top of it, and this just creates nose breathing versus mouth breathing. Because if you have that appliance in your mouth, there's a little space there, and you're going to want to have a tendency to breathe through your mouth. And so we made this little device made out of silicone, very, very soft silicone. It just fits over the flex tap as you put it in. It looks like a pacifier when you have it outside your mouth, but it works. And just creates a better way of breathing through your nose. Mouth taping. I do this all the time. I use mouth tape every night. And I don't use duct tape. Don't use duct tape, okay? But, so what I use is this NextCare paper tape. It's a 1-inch wide NextCare. You probably use it in athletic training, right? Especially when you're doing type of things. You can do like on the left, you can do a 1-inch piece just up and vertical. I have a mustache, so I have to go horizontal, right? But you can do that. And there's one on the market that was on Shark Tank called Somnifix, and it has a little bit of a hole in the middle. sound fix will cost you about $30 for about a 30-day supply, right? Nextcare paper tape is about $3, and it'll last you about 2 months. So, I mean, cost-wise, it's better to do it this way, right? So what I do is I fold the edges around this thing so that it does, you can grab it, because if you have it perfect, you got to peel it off a little bit. It doesn't peel off your skin, which is a good thing. The other thing that you can look at is on your iPhone. If you have an iPhone or usually on any phone you can do this. There's an app called Snore Lab. I use it daily. I use it every day to track my sleep. You turn it on, you turn the phone face down, you plug in your phone, put it right next to your bedside, and then it tracks your snoring. Especially when a husband says, or the bed partner says, I don't snore, and the spouse says, oh yeah, you do. I have the spouse sleep in a different room. We put the Snore Lab app on, and then they bring it into me, and boy, it's like, man, I do that, and you can hear it. You can hear it. So here on the left, this was me without mouth taping. 35 is actually not too bad. And then with mouth taping, you can see it just decreases there. So treatment options. There's a thing called a Snore Gym. It's by the same company as Snore Lab, and you just do exercises for your mouth to create muscle, to increase your muscle tone. Because like in everything, as we age, our muscle tone decreases. And this is a new one that's out there called a Power Breathe. I have one. It just really shows you how to breathe. You know, you've been where you've had an injury, and when I had surgery about 3 years ago, and they had me breathing and blowing on the little bubbles, you know, to get the bubbles to go up, and man, that's tough, right? And it's just all about breathing and to increase effectiveness and health. And so this one called a Power Breather, you can get it on Amazon. It's like $60. And it just really trains you on breathing. You wouldn't think that you need training on breathing, but it does make a big difference. Now, these are called nose cones, right? You've all seen the Breathe Right strips where you put it across the bridge. We have a little valve here that can be dilated. Especially when you have somebody who has an injury like Christian was talking about, Dr. Starkworth was talking about, where you have a deviated septum or something like this. You can't breathe well out of the nose. Again, you're going to start creating sympathetic breathing through your mouth. So we wanted to remedy that. So these little nose cones, you can actually put them in. They're soft silicone, and they have a little lip, and I'll show you right here so you can see it. There's a little lip that stays on the outside of your nose so you don't take it up into your nose, right? And they're very, very soft silicone. The lady or the company, I know the company, the CEO really well, and she sent me a bunch of them, and Sean has them over there, so you can take a pack. They have in different sizes, so you can try the different sizes. I don't know if I brought enough. I thought I brought enough, but if I didn't, you can just, there's some brochures in there, you can order them. They're very, very inexpensive, and you can order them and try them on yourself. It's also, we use them in improving endurance and breathing for football players and basketball players on the court, because it opens up their nose while you've seen some of those where they put a Breathe Right strip when they're playing football. Well, you can put these nose cones in there, and it increases the airflow. So there's also one called a sinus cone that goes in a little bit deeper into the nose. Now, a green beetle, all right? How am I doing? I'm doing pretty good here. A green beetle, all right? Have you ever seen one of these before? I tell you, within the next 4 days, you will see at least one. Trust me. You're going to see at least one green beetle between the now and the next 4 days. Why? Because now you're looking for it. Same thing with obstructive sleep apnea, sleep disordered breathing. You're going to see it. You're going to look into the mouth. You're going to see tonsils that never really made anything different to you. You're going to see worn front teeth. You're going to see dark circles under the eyes. You're going to see somebody who's not paying attention. Those type of things are now you're aware of it, and that's why I was going to talk to you about it. Now your eyes are open, right? So this lovely lady here, this lovely lady is my mother. My mother died from complications from sleep disordered breathing in 2011. And I made it my goal to not let anybody go through the hell that we went through with this. Now, my mom didn't die because she didn't breathe right, but she had OSA. I tried to make her an appliance that she could wear, but my mom was a beautiful lady. She was a hand model when she was young. You know, they'd hold up, you know, bottle of perfume or something like that, and they used to take it for Life magazine. We have pictures of her with her beautiful nails and stuff. But she had beautiful nails, and she didn't want to take the appliance out, afraid she would break her nail. And I was like, come on, Mom, you got health first. But my mom died from, she aspirated one evening on July the 26th. She ate a Nutty Buddy ice cream cone about 8:30 at night. And then she had really bad reflux that night because of her OSA. And she aspirated it into her lungs. And then she got an aspiration pneumonia. She spent 2 weeks in the hospital and then re-aspirated it again in the hospital, and she died of that. She was 72. No need for her to die from that. This is serious stuff. You need to take this into account with yourself, with your athletes, with your family, and to be recognized what's going on with that. This is another thing that I'm working with this company. I don't get any remuneration from it, but I use this in my office every day, and it's called Quick Splint. And it's a little bit of, I take a polyvinyl impression material, I put it inside there, and when somebody's got joint issues, and I put this in my office. This is also very effective for somebody who has gotten a jaw injury on the football field, on the basketball court, and that they're having a lot of TMJ pain. We can make one of these things. You can make one of these things. It's just a polyvinyl impression material, and it's like a little putty, and you put it in there, have it put in there, make sure the teeth are nice and even. If you want to know more about it, let me know, and we can do something in my office. And for anybody who wants to come in, we do a little clinic on that. So just really helps on that. So if you want more information, there's a QR code. You should have it in your PDF. Right? Any questions? So I went through it kind of quick. So yes. Yeah. I've not heard anything about that, but I know that if you, I know that in recovery, if you have them breathe through their nose, even though they go, I can't breathe, I can't breathe through my mouth, I can't breathe my mouth, you slow them down because they can overbreathe, and what happens is you take off too much CO2, right? And then you're going to get lightheaded, right? And you need CO2 for that change of oxygen from your air to your lungs. If you don't have CO2, the air can't get into your lungs. So that's why we breathe in a bag, right? And because we replenish the CO2 in our lungs. About to faint, or I can't breathe, hyperventilation is not caused by a lack of oxygen. It's caused by a lack of oxygen because there's a lack of CO2. So we got to get the CO2 back in. So whether they lay down, lay on their side, breathe through their nose is probably the best thing to slow them down. And if you have to, that's